Hi, and welcome to Integrative Cancer Solutions with Dr. Karlfeldt. A cancer diagnosis is one of the hardest slap in the face imaginable. All of a sudden, you have to become an expert in cancer and its treatments because your life depends on it. Oncologists, family, and friends are pushing you towards chemo, radiation, surgery, yet you feel there are additional solutions out there. You don't feel confident in that only traditional therapies will take care of it. You may, as I have, seen family or friends quickly go downhill from harsh medical treatments. There is a better way. I invite you to listen to stories from real people fighting cancer successfully through powerful, integrative, and holistic methods. Learn what they did. This is my gift to you to make the learning curve less steep after your diagnosis. The information in this podcast could save your life as it has others. With me, I have my dear friend, Dr. Shah. Dr. Shah, thank you so much for spending some time with me today.
Dr. Michael, it's really an honor to be with you. I've seen your profile. We talked at A4M, and it's very impressive, and I'm glad I have time to talk to you.
I mean, first, kind of explain a little bit who you are. I mean, you have, your background is just phenomenal. You're someone that's sought over all over the world. So I would love to people really to understand kind of where you're coming from and the authority that you speak with.
Sure. So understand, just for background for your audience, my family, we're a family of doctors. My father is a physician. My brother is a physician. One of my sisters is a dentist. Our grandmother was a traditional healer, right? So they call her Hakim, or because she's female, Hakima. So she was a traditional healer who used all kinds of homeopathic medications to treat patients. So the philosophy that I was given, I remember when I was entering medical school, and I remember my dad took me aside before, and he goes, remember one thing, the first thing, and I want you to keep this in your mind always, when you treat a patient, you treat them like you would treat your family member. So if you're going to recommend a therapy, you're going to recommend a medicine, you're going to recommend a complex procedure, you make sure in your mind it's clear that if it was your brother or your sister or your dad or your uncle on the table or on the other side, you would make the same kind of decisions that you're going to make with the patient. And I adopted that philosophy. And I can tell you, because I was at McGill University, where I did my medical school, William Osler, who was one of the deans of modern medicine, was a big influence in our training. We were taught Oslerian principles. We were like assigned time at the Osler Library. And we would go to the Osler Library, we'd read some of it, and the man was a genius. I mean, the man was way ahead of his time in how to treat patients. And his approach was a holistic approach. If you read some of his quotes, he says, you don't treat the patient as a disease. This is a human being in front of you. Everything about that human being is very important to his diagnosis. The tremble in his hand, slowness of his speech, or, if he's crying or whatever, like those are all you have to take into account. So that combined with my father's philosophy and our family philosophy, and it was a great synergy for me in how I approach patients even now. So I did medical school in Montreal at McGill University. And the reason I went to McGill was because of malpractice issues in the US, students are not allowed to do anything, like nothing. The students, when they're in the operating theater, they can barely just get gloved on, and that's it. And I wanted to be a surgeon. I knew I wanted to be a surgeon of some sort. At that time, I wanted to be a neurosurgeon, so I knew I wanted to do brain surgery. And so I went to McGill, great training, Canadian medical schools, nothing against American medical schools, but Canadian, I think, are better, having seen both. And so the Canadian training is very rigorous. It's very hard, but it's very good training. And they let you have hands-on. So as a third year, I was assisting in tonsillectomies. By fourth year, I was allowed to do them with supervision, of course, by myself. Same with appendectomies. So they give you a lot of freedom and you learn a lot. So that was the reason I went to Montreal. But when I got there, I met some interventional radiologists and neurointerventional radiologists, and then I decided, you know what, I want to be. Now we call ourselves neurointerventional surgeons. A little pretentious, but it's a title that the national organization has adopted, the Society for Neurointerventional Surgery. We do minimally invasive procedures in the brain and spine, basically. So I guess it qualifies as a surgery. But anyways, so I did that training in Canada, and then from there I went to I initially started in trauma surgery program, and then I didn't want to do that. Then I went to the US for training. So I did my radiology 5-year residency. After that, then I did interventional radiology, and there's a lot of interventional oncology with that, because interventional oncology is one of the disciplines of interventional radiology. There's like vascular intervention, there's body intervention, and then there's interventional oncology, which interested me a lot. So then I did that interventional oncology, interventional radiology, and then I did 2-year neurointerventional fellowship, in which I did a lot of pediatrics also.
I mean, first with radiology, with radiation, doing that. Talk to me a little bit about, is that something? Because a lot of people are afraid of radiation. They're afraid that you're radiating a spot, and then all of a sudden you're creating an environment that is very inflammatory, and then your risk for other types of cancer elsewhere showing up. So, do you mind just kind of going through the logic a little bit with radiation for patients that are?
Yes, radiation oncology is a separate specialty, not for mine, but I work very close. In fact, I'm going to a congress in radiation oncology in January 31st, and I think it's in Abu Dhabi, and I'm giving a talk there. I think like every modality, it has a specific use, and sometimes do they use it a little bit more than they should? Yes, sometimes, but the technology is improving exponentially. Just like anything in computer related things, the curve is amazing. So, they have CyberKnife and Gamma Knife, you might have heard of. CyberKnife is amazing, where it does a rotational radiation field. So it basically, and they have AI now software to help plan it, right? So the AI is very good at seeing things that even radiation oncologists might miss. So the AI will say, okay, the planned path of radiation exposure should be like this. We do what's called tight collimation of the radiation beam. Now, that being said, you make an important point. Yes, but you cannot always control where the beam goes. Like, you will control where the center target is, where the radiation beam is diverted by the human tissue. There can be some effects, and as you said, inflammatory effects can definitely be there. If you go to a radiation oncologist and you have to make that decision, do I take the radiation or do I not take the radiation? You have to talk to him very carefully and ask the right questions. So commonly for radiation oncology, like, is a pancreatic tumor, right? A deep pancreatic tumor is hard to get surgically, but you want to make sure that the radiation, when you tell them, okay, so when you guys do the collimation beam, which other tissues could be damaged? What will that damage look like? And then how do I ameliorate that damage? What supplements should I take to help control the inflammation? What supplements should I take so the body recovers from the radiation treatments? What kind of diet should I be on to help me recover? Because it's just like a surgery. And we know that post-surgical nutrition in this country is horrible. The surgeons operate, or somebody operates, and they forget about the patient. Like, oh, we'll see you in follow-up in 2 weeks. Well, you know what? This person's still healing. So they need proper supplementation to heal properly and to heal faster. And especially cancer patients, most of all, because cancer is already phagocytizing their food supply, right? The cancer, by drawing vessels, with the neoangiogenesis, is already taking basically nutrition building blocks away from the patient. That's why a lot of them become cachectic very fast. I mean, cachectic is the word we use for they become skeletonized, right? So nutrition, this is one of the prime things. When I treat a cancer patient, I tell them, listen, I'm going to do the procedure today. I'm going to ablate your kidney, or I'm going to ablate your liver, or I'm going to ablate your lung, or I'm going to ablate whatever. It's a surgical operation. Think of it that way. And you're going to need surgical recovery time, and you're going to need post-procedural surgical nutrition. And they'll be like, doctor, what are you talking about? I'm like, no, you have to be on a high protein, low carbohydrate diet. You have to get all your supplementals. You have to get your elemental nutrients. You have to make sure your micronutrients. I prefer if you can get cytosolic testing of the inside of the cell, right? Not the outside. So the blood is outside, right? I want to know what's going on inside your cell. How is your nutritional status inside the cell? Which elements are maybe missing? And then you start supplementing with those elements so that you are optimized for post-procedural healing.
I love that. Love that. And I know when you and I chatted, you said, I can pretty much go in and surgically do pretty much anything, place whatever it is that you want to place anywhere. And I know you do a lot in the regenerative space. You've treated high profile people. And so in the cancer world, though, what are some of the things that you are seeing around the world that you say that if a family member of mine had cancer, these are the therapies that I would like to be able to have?
Yes, excellent question. And thank you for that opportunity to explain. Yes. So because I was in Dubai, and this is going to sound like a plug for Emirates Airlines, but it's not. But Dubai is a logistical hub for Emirates Airlines. So I was able to travel all over the world. I put lots of miles on luckily it was paid for by companies because the company sometimes would offer you cash, and I would say, please do not, like, I'm an American doctor, do not offer me cash for anything. But what I will ask you to do is help me be a better doctor. And so if I want to go to China to go see a specific procedure, you guys will pay for it. and it'll be to the benefit of you, your benefit. It's a win-win for all of us. So I took that, I took massive advantage of that opportunity. So I went to China, I went to Japan, I went to Australia, New Zealand. I started finding experts who were the experts in whatever field they were that were applicable to what I do, right? And some of them even were not applicable, but I wanted to learn some things and learn some new procedures. So I took full advantage of that, and I did learn some stuff. And I would say in the cancer field, I mean, hands down, the Chinese are the most advanced right now. In cancer therapies, I can tell you, knowing what the protocols are for most cancers, what are the American, oncology guidelines here, like, the Europeans, they have ASCO or ESCO or ESMO, to use those guidelines in evidence-based medicine to make your decisions. But at the end of the day, when you make the end decision on what you're going to do therapeutically, that's what you all talk about precision medicine now. Right? I mean, precision medicine is a new buzzword. And precision medicine is not anything different. It's just a different way of describing it. But you treat each patient independently and individually as that patient, because they have many different variables, and you have to take all those variables into account.
And so in China, I mean, what are they doing there that we are not doing here?
Good. Yeah. Excellent question. So I'll go through a few of the modalities and how they use them, and how they're not really available in the US, unfortunately. So, for example, there's a few of the cancer hospitals where the interventional oncology guys run the unit. They have oncologists, they have radiation oncologists, they have everything, but they know that the interventional guys will do things out of the box. And they're not aware of those procedures because they're not trained in those. So they don't know what these guys can do, what's in their toolbox. They don't always know, but the interventional guys always know what's in their toolbox. And so for example, for liver mets, right? So you have a liver met in the liver. There's multiple ways to treat it. The most common way in the US is to put them on some kind of chemotherapy infusion. And that's not ideal, because now you're exposing the whole body to systemic chemotherapy. And there's certain parts, especially like the gut, the hair. Why does hair fall out? Why do they get diarrhea? Why do they get all this? Because those are actively dividing cells. Hair follicles, actively dividing cells. Intestinal cells, actively dividing. So when you give systemic therapy, you're killing all those too. Probably not a very efficient or very precise way of doing it. The precise way would be what these guys do. They will do a catheter-directed chemotherapy. So they'll go into the hepatic artery, they'll do a shot of contrast, they'll see the tumor light up, and then they'll deliver that chemotherapy right to that specific metastatic disease, that specific metastatic focus. It's brilliant, just brilliant. I mean, now there are some cases in the US, there are some doctors that do it here, but it's not in the guidelines, right? It's not in the NCC guidelines. You look through the NCC guidelines, usually interventional oncology and radiology, these are considered, you can do this if they failed first line, second line, and third line, and then they're experimental level, then you can probably do this. Why not? If you are precise, you can do something image guided. You can deliver an agent right to where the tumor is and spare all the natural tissue. Spare. Why are we doing this kind of stuff? So that's one. So that's one is intraarterial chemotherapy, which there's still parts of the body we don't do it, and I don't understand why. For example, the brain, we don't do any intraarterial chemotherapy, and guess what? Because of the blood-brain barrier, it's very difficult to treat brain tumors. That's why glioblastoma still has a very high mortality and morbidity, because you can't get all the chemotherapy you want, and you can't even with radiation, with the skull and the way the skull will deflect, and how much tissue, how much radiation absorption there is into that tumor is still variable, right? You can have a gamma knife. You can have a gamma knife is most commonly used for stereotactic radiation, but a cyber knife also works, and cyber knife is accurate to like 3 millimeters, right? So the radiation dose it's not outside of that. Whatever you designate as an area, it's very precise. But even despite that, we don't always use all these things that we can use in our toolbox because we follow the guidelines. Well, the guidelines say for glioblastoma, you should do first line therapy first, and then second line therapy, and then fourth, third line, and then you're into the experimental therapies. And now we'll go, and it's always like the same thing. You know what? We failed all these therapies, we failed everything, and now we're going to do experimental things on you. You know what? Why don't we do the experimental things at the beginning? Right? Because your guidelines, the efficacy, they don't work. I think chemotherapy is a very good, in certain cases it's good. But what chemotherapy does is, and what you have to remember is it selects for all the chemosensitive tumor. So you select out all the chemosensitive tumor, and what are you left with? You're left with the more aggressive chemoresistant tumor. And that chemoresistant tumor comes back at a horribly fast pace, right? And so somebody who's, initially stage 2 rapidly becomes stage 4. And then everybody's surprised, right? And Dr. Shah, I'm the guy who always says the thing that nobody else is going to say. That's just me. And I say, you guys did a great job. You killed all the chemosusceptible cells. You left the chemoresistant cells, and it made a comeback. And it's doing what you programmed it to do, basically. Like, you selected for the most resistant tumor, you got it. You converted the patient from stage 2 cancer to stage 4. And then they usually respond with, Dr. Shah, could you please leave the room? And I'll be like, okay, fine.
That's the thing. I was chatting with a good friend of mine, medical oncologist, and he was saying, I mean, the challenge is to get the chemo, obviously, to the tumor, to the cancer. And if you're able to get even 5% of the chemo into the cancer, then, I mean, you consider yourself lucky. And then, like you're saying, for the glios, for anything in the brain with the blood-brain barrier, obviously that percentage is reduced dramatically. So, here we are essentially then starting with a therapy that's depleting the immune system, that is putting more stress on the body, that's selectively getting rid of the easy to kill cancer cells, and the dormant, hard to kill, the cancer stem cells, they're still there.
Exactly.
Yeah.
That's a brilliant observation, because those cancer stem cells are the source. And you really want to go after those stem cells. I remember, your body does it every day. Your immune system is a hypercharged super defense system. They're like, special forces soldiers. They target and go after. And so when you have 8 to 10 cancer cells a day being produced, guess what? Those special forces soldiers take them out every day, in and out. That's what they do. So what I believe, and my philosophy on cancer, is that let the immune system do its job, right? Make whatever you do to the cancer, kill it enough so that the immune system can just take over. And that's why we have checkpoint inhibitors now. Now we have immunomodulatory cancer therapies, right? Because finally the oncologists have realized that, we're just selecting for chemo resistant cells. So we need to work on the immune system and help the immune system in its battle against cancer, because the immune system can take cancer away, and it's very good at it. It's much better than we are at it, right? Because I remember, even at MD Anderson, I remember, so the cases that stick in my mind when I was there was, there was one patient who had a massive lung tumor, and it was a adenocarcinoma, very aggressive, so very large tumor. And but the patient was very smart. The patient did their research. They had long consultations with Dr. Google all the time, and Dr. Google gives some good advice. Dr. Google gives some very bad advice. But this person was very intelligent, a critical thinker, and started doing naturopathic treatment with a naturopath. Found a good naturopath who had oncology experience. Started working with an oncologist that was open. And understand, people will say, well, why don't the oncologist do this? So understand, when an oncologist does things that are not in the guidelines, he's taking a risk with his medical license, because there's a lot of paid. Can I swear on this podcast?
Well, you can say darn.
Yeah. Okay. Yeah. So there's a lot of darn tootin' oncologists who will be paid by a malpractice lawyer to say that what Dr. X did is not in the guidelines, it's not accepted, it's not this, it's not that, and what he's offering is not part of this, what you call the standard of care. And so what he did was, I give so much credit to oncologists who are willing to go outside the guidelines, because they know they're taking a risk, but in their heart, they know they do the right thing, and they can prove it with evidence. But then it's a very painful process to go through a malpractice case. Very painful, because there's depositions and there's this, and you have to defend what you did and why you did it. For most physicians, a malpractice case is like a death, because you go through all those emotions, grieving emotions, everything, like very bad. At that point, they become gun shy. They will not do anything that is not in the guidelines, because they already went through that one time, and it was painful. And so, I understand the realities of why doctors in the US don't do certain things, because it will be hard to defend that in court. And physicians who work in the US, we always have to think about that. We have to practice a form of defensive medicine, where we take certain decisions, not because it's the best for the patient, but because it's the best for us not to get sued. Me, I don't believe in that. If this lawsuit comes, I'm not afraid of a lawyer. Whatever. Because I know what I did. I know I did the right thing for that patient, and so in my heart, I'm okay with it. I don't care what the lawyer's going to do.
That's the thing. I mean, the oncology profession here in the United States is such a heavily regulated, and it's regulated by your peers, essentially. Like you're saying, is that if you don't follow the line and you're sticking out, the peers that are, they go right after you. And you were talking about in regards to the medicine that I would like to receive if I have the disease. That is a medicine that I will give to my patient. And it's interesting in regards to it's a question that was posed then to a group of medical oncologists that if you had cancer, would you do chemo? And 70% of them said no.
Never. No, they are the most experienced people in cancer therapy. They would not take chemo because they know some types of chemo just don't work. Like they know it doesn't work, but because the guidelines say to do it, that's what they start. The really brave ones, what they'll do is they'll say, let's do 1 or 2 cycles. Okay, it didn't work. So let's quickly move to line 2, or let's quickly move to the experimental. Like those, to me, I tip my hat off to those oncologists. They are brave people. They know it's not going to work, so they quickly go to what they think is going to work. I mean, that's bravery under pressure. That's commendable. That's really honorable doctors who have not forgotten their Hippocratic oath.
And in regards to you talked about after radiation nutrition and then obviously there's so many natural substances. There are repurposed drugs. You have peptides. What are some of the kind of cutting edge that you're seeing in that world that you're seeing having an impact?
All these kind of amazing things we're seeing in medicine recently all came from the Russian military super soldier experiment. And your audience may not be aware, most people usually don't. The Russians were trying to build these super soldiers. They wanted them to be to resistance to heat, to cold, to temperature variations. They want them stronger cardiac output, stronger lung function, like all these things. What they started doing is they started experimenting with different therapies. So from that experimentation came out photobiomodulation. So everybody knows nowadays, everybody knows about red light therapy. There's like YouTube videos everywhere about red light therapy, but red light is just one wavelength, right? And the original super soldier experiments used UV light actually. So they used to have an external circuit from the artery to the vein, and that tubing would then be exposed to UV light. And they would do it for months on these patients. And the same thing with the Russian cosmonauts, right? So the cosmonauts were part of that super soldier project because they wanted those cosmonauts to be very resistant to everything. And so what they noticed was they were able to increase cardiac output 10 to 15% in these people. They were able to increase total lung capacity, functional residual capacity, FEV1, like all the lung parameters that you do on a pulmonary function test. They were able to improve 10, 15, 20. So these are basically Spetsnaz, special forces, and the cosmonauts, right? These are the elite of the Russian military and space programs. They would get these guys like heat shock proteins. They would increase their heat shock proteins. Cold shock proteins. They would increase his cold shock proteins. So guess what? Now you have a literal Captain America type of person where you took this soldier and now you convert him to this thing, and he's resistant to heat. He's resistant to cold. His thyroid function is optimized. You can put him you can put him in a cold situation, hot situation. He will survive. He'll do great. His lung capacity is great. So now you've increased our endurance capacity 30, 40, 50%. They're super soldiers, and they were successful in doing this. And a lot of the medical stuff, guess where peptides came from? Guess where bioregulators came from? It all came from those experiments. And when the wall fell, those people came over to Germany, France, US, whatever, and they started asking for these things that were very common in Russia. And they would come and say, I want the light therapy for my blood. And the doctors from Europe would say, what the hell are you talking about? Light therapy for the blood? We don't do light therapy. Then they would explain, they stopped doing the tubing and they started to put the light directly in the vein. More cardiac output would then be exposed to that light, right? So you'd supercharge all your mitochondria. In 20 minutes, your whole blood circulation will go past that light 3, 4 times, depending on how fast your heart rate is and how good your cardiac output is. And so you would expose the whole blood circulation 3, 4, 5 times to the light. And so these people came in and they would feel great, right? They would be healthy. Their immune system would charge, their mitochondria charged, they have lots of energy, no brain fog. And so when the wall fell and they came over to Germany, they started asking for this. And the doctors were like, what the hell are you talking about? We don't do light in the vein. It reminds me of like when Trump came over and he started talking about putting UV light into the body, talking about when he was trying to treat COVID, everybody started making fun of him, right? So Trump has his own issues, whatever. But that was really not a bad idea when he said we could shine UV light. Because guess what? It was done in Iran. During COVID, they started doing the UV light into the lungs during COVID. And guess what? Killed the COVID. The 1905 Nobel Prize was given to a doctor for solarium therapy for TB. So of course not pulmonary TB, but extrapulmonary TB. You got amazing results with heliotherapy, right? Sunlight. heliotherapy, which for thousands of years has been healing in every culture. You can Mayan, Aztec, Egyptian, Sumerian, Chinese, Indonesian, Arawak Indians in the Caribbean. Like all of these people use heliotherapy to treat. The sun is an amazing source of healing, and not
Yeah.
just vitamin D, right? Not just vitamin D, anti-cancer, antibacterial, antifungal, mycobacterial, heliotherapy. Now we're rediscovering it. I always tell people there's a lot of knowledge about the human body that we have lost. It's not that we don't know. No, we had it. The human consciousness had it at one time, that knowledge, but it's been lost. And to me, that, it's very important to get that knowledge back.
And that's the thing. I mean, that's fascinating because we talked about cancer, cachexia, how the cancer divert blood flow to itself in order to be able to feed itself, because obviously it's not very efficient metabolically. So it needs a lot of substrates and needs a lot of substance in order to be able to survive. So
Right, so that quickly, and I'm so sorry to interrupt you. I apologize. That quickly jumps to one of the things that I really want to talk about is embolization. So an underutilized therapeutic form, which we have for more than 40 years. We've been doing embolizations in interventional radiology for more than 40 years. We know that we can cut the blood supply to anything. I can cut the blood supply to any tumor anywhere in the body, just about 90%. 90%, I can cut the tumor. I can cut blood supply to any tumor. We do it for fibroid embolizations every day. Now, those, of course, those are benign tumors, but if we can do it to a benign tumor, we can do it to a malignant tumor. Underutilized.
So why don't we? Because that seems like such a powerful tool. If we can starve the cancer by cutting its blood supply, then why don't we?
Yeah. So some of us do. Some of us do it in Pakistan. We do it in Mexico. We do it in where other countries where we don't follow the guidelines. We do it as best for the patient. So we do it, and we can do it. And the reason that we don't do it again in the U.S., it's not part of the guidelines. Even though it makes to you and me immense common sense and immense medical sense, it's not part of the guidelines.
The point I was going to make with the breathing is that if you're able to divert blood flow to any location, you should also be able to divert blood flow from any location away from it. With using these type of techniques, you should be able to actually theoretically control the amount of blood that is then going to the tumor.
So understand, like I'm a big believer when a patient gets a diagnosis of cancer, they should use every means possible because we have an enemy and you have to fight the enemy, and you use every tool that you have available. So if you can go learn pranayama breathing and learn how to divert blood flow away from, do it. If you learn some certain nutritional things, like dandelion root, right? Dandelion root is immensely immense anti-tumoral properties, right? Use it. Repurpose drugs. We know ivermectin, we know fobendazole, we know curcumin, we know methylene blue, we know all these things are available. To me, cancer is like the worst enemy in all of medicine. In all of medicine, cancer is the worst. And the reason it's the worst, because it's devious. It's a very devious kind of disease where it avoids everything you do. You do this, it changes and does something else. You do this and changes again and mutates again, because we're talking cancer stem cells. Those cancer stem cells, highly immunogenic, right? So amazing mutagenic potential. So they will divert. And again, chemotherapy, we're going to change the cell. Radiation therapy, guess what? The tumors, we're going to make our guys radio resistant. Throw it. What else do you guys have? What else can you throw at us? Oh, nutrition. You know what? We're gonna change some tumor cells which don't need that specific elemental nutrient. I like to personify these things when I talk about them, when I talk to patients, because the tumor is your enemy. We're on the same team, me and you. Let's fight the enemy. And anything you do, I will accept if it makes sense, some kind of scientific sense to me. And if some things don't make scientific sense to me, I'll give you the benefit of the doubt. And if it works, great, excellent, because we just kill the enemy, and that's our goal. Kill that enemy, eliminate that enemy. So we have what we call in our field NED, no evidence of disease. That's our goal. And hopefully no chance for it to ever come back, because cancer is a devastating diagnosis for some people. You have to use every weapon in your toolbox to fight it.
And I don't think a lot of people recognize, I mean, we're talking about the tumor, but what you're really highlighting is the intelligence that exists. It's not just a lump of tissue that you're dealing with.
Exactly.
It is a very complex, intelligent and you said devious, and it's geared for survival. So it is geared, it's a very kind of, what's it, a primal type of
Exactly. No,
programming.
no, because cancer cells are basically a very immature cell. That's what cancer is. It hasn't gone differentiation properly. That's why it becomes cancerous. When a cell becomes fully differentiated, they don't become cancer. The terms we use in even histology is this is an undifferentiated carcinoma. Oh, so an undifferentiated carcinoma means it's an earlier form of the cell, very aggressive. It will, as you said, it will do everything it can to continue propagation of more cancer cells. Like that's what their job is, to create more cancer cells. And it will parasitize blood vessels. It will parasitize nutrients. So this is one thing I really want your viewers to think. You can do chemo, radiation, this, everything, and we don't see any cancer. We don't see it. Well, guess what? One or two cells can hide in many different places. They can hide in the bone marrow. They can hide in a blood vessel wall. They can hide in like the most amazing parts of the liver, which unfortunately with the imaging that we have now, we can't find it. We can't see it. It's too small and it's hiding. It's just waiting for the next step. I remember I learned from Dr. Michael Weber, not the Michael Weber who made the machine, the other Michael Weber who was in Portugal. We were talking about circulating cancer cells. He goes, do they do circulating tumor cell assays? What? So I said, what? He goes, when they're treating cancers, do they do circulating tumor cell assays? I'm like, bro, what are you talking about? He goes, the circulating tumor, the tumor that's in the blood, the tumor that's you can't see it in imaging, you can't see on any kind of lab test, you can't see it, but you have to do like these specific assays. If you have the tumor histology, you can build a reactant that will then, if it finds that tumor in the blood, it will tell you how many tumor cells you have in the blood. Then you know what to do next. Well, what? I already knew some tumor biology, but we never talked about this. But the Europeans talk about this all the time, right? Especially these guys who do specialized chemo, like cancer therapies, right? Like stuff that's just, very. I mean, Michael was just amazing because one of my nephews, so age 14, got colon cancer. Okay, so colon cancer is not a disease of 14-year-olds almost ever, unless you have some kind of genetic mutation, like FAP, like family adenomatous polypoid syndrome, right? Cancer doesn't occur in 14-year-olds because you need 10 years of damage to the colonic wall to get the cancer, right? Then one or two cells will mutate into a cancer. So 14-year-olds don't get cancer. And my cousin, he decided to do the British guideline because they're in the UK, right? So he followed the British guidelines, and unfortunately, my nephew died.
I'm sorry. That's a horrible thing, is that you follow the standard of care and you place your trust in that system because you feel these are the experts. This is what they do day in and day out.
Yeah.
And so this got to be the best therapy. This is what's been researched. Otherwise, they wouldn't do it. If it was something better out there, they would be doing it. So that's kind of the mindset you have as a patient, not recognizing that it's not correct. This is.
I don't know. And he went. My cousin, cared for his son a lot. He took him to Great Ormond Street. Great Ormond Street is the best pediatric hospital in the UK, in London. It's one of the top 5 in the world. But like, how many colon cancer cases do they see in 14-year-olds? Not a lot, right? Not a lot, because they know it's not common, right? So they had to, but again, they followed the guidelines. And Michael Weber, to his credit, offered to do the treatment for free. Just amazing guy. And I call it a propaganda. I mean, it's pharmaceutical, big pharma propaganda, this kind of thing. And so he said, no, I trust the doctors at Great Ormond Street. They're the most amazing pediatric oncologists in the UK. And I'm just going to follow their guide. Whatever. He died.
And that's exactly what you're saying. The last number of years, we've seen some things that we haven't seen before, in regards to cancer. And I've seen
and bro, it's a spike protein. The spike protein has great mutagenic potential. The spike protein, whoever designed that spike protein, I'm not going to mention the name, in North Carolina, he knows who he is. And you know what? On this podcast, I'm calling you out. You know who you are. You know what you did in North Carolina, and you know who you sent to China, and you know how you trained her. So I'm just putting out there. Everybody on the internet, look it up, because it's everybody. The DARPA guys know, the U.S. government knows, the CIA guys know, and believe me, the Chinese know. Because you know why? The Chinese locked her down. immediately because she had an extraction team sitting in Hong Kong to take her out. Sorry, I'll take you down the rabbit hole. I'll take you down the rabbit hole.
I don't mind rabbit holes,
Yeah. So I'm taking you down. So as soon as she delivered the agent to where it was supposed to go, she was supposed to be extracted with her family. The extracted team was ready in Hong Kong to take her out. And the Chinese are very inventive people. I give them credit. They locked the country down like a steel trap. No buses, no trains, no motorized human-powered vehicle. Nothing could move. Nobody could move at all. And she got busted. And now she's appropriately, I'm sure, being tortured in some nice cell in China somewhere. And she deserved it. I'm not going to go there. I'm not going to go the rabbit hole anymore. Sorry.
Yeah, because I mean, the Chinese government is continually monitoring. Yeah.
And to their credit, no, listen, to their credit, they're smart. Because if you have an enemy, you know that enemy is devious. You have to use the same kind of devious means the enemy's using. It's what's good for the goose is good for the gander.
Yeah, exactly. I love it. Yeah. Anything else that you feel, for the listeners that are battling cancer, that are wanting to know kind of what's out there, anything else that you feel we should highlight that's important?
Yeah. So without plugging specific hospitals, but if anybody wants to contact me, I can give specific hospitals. But I think whenever you get the cancer diagnosis, get all your medical reports together and then send it to China. They are very experienced. They have multiple cancer hospitals in multiple beautiful cities. China is an amazing country. So send it to these Chinese hospitals, ask for a second opinion. Usually they'll do it for free. So you send them all your imaging, send them all your lab reports, especially the histology. The pathology of the tumor is very important. Send it all to China and just get a second opinion. I always tell patients, you should never be afraid to get a second opinion. I don't care. It's your body. The tumor is inside of you. So avail yourself of any type of knowledge you can get and send it for a second opinion to the guys in China. There's an amazing interventional, and I have not, you're connected to him. Hopefully I can get an introduction, but he's amazing. His name is Jason Williams. He has Williams Cancer Institute in Mexico. He's doing amazing stuff. So if you're in the US, you know what? I'm plugging it, and I have no financial relationship with Jason. I'm still trying to get in contact with him, send him multiple emails. He's such a busy doctor. He hasn't even had time to respond to me, but he's brilliant. Look at his LinkedIn posts. I mean, he's like one of my idols in interventional oncology. I mean, I think the stuff that he's doing is groundbreaking, and I'm hoping to build a similar type of cancer institute in a few different countries.
I'm just curious. So in China, what you send records to China, which are some of the hospitals that you would say,
So you want me to give that? You want me to give the names? And
I would like to, actually. Yes.
So if you guys are listening in China, I'm giving you a free plug here. So I expect at least a coffee from this. So Guangdong Cancer Center, Guangdong, very good, amazing doctors, amazing, really brilliant. And in Guangdong, there's another cancer hospital, but I don't remember the name right now. Guangzhou or Guangzhou. So Guangzhou, Guangdong, Fudan has multiple cancer hospitals, right? So Fudan is like a cancer brand. So they have multiple hospitals. These are the ones that come off the top of the mind. I'm sure if you guys give me time, I could go to my LinkedIn and get you a whole list.
Kind of final discussion. I mean, we talked a little bit about photobiomodulation, and
yes.
You talked about Dr. Michael Weber in Portugal, and then we have Dr. Michael Weber that's in Germany as well. I hear you had the Russian super soldiers, and the way that was treated was by treating the blood. And here we have the technology, like you're saying, where we can put in then an optic needle into the blood vessel, into the vein, and then treat the blood as it's passing by. So that way, instead of just treating a small amount of blood, we are essentially treating the whole blood volume. Yeah.
Correct. And 3 or 4 times. In a 20-minute cycle, 3 or 4 times you get all the blood that goes through. So you've treated the entire circulatory volume 3 or 4 times with one needle being in for 20 minutes, right?
Yeah.
So the way Michael did that, right? He got these patients asking him because he was doing acupuncture, he was doing some advanced kind of stuff that nobody else was doing. So the patients would come to him, the Russians would come to him and say, we want this treatment. He's like, again, what are you talking about? Putting light in the veins? Nobody does that in Germany. But because he has an open mind and he's a chemical engineer, like you also, right? Engineering background. That's why I love when doctors come from varied backgrounds. They're not just bio majors, they're engineers. They think engineering, they think in a different way. Like your approach to medicine is very different from another naturopath who went to the same naturopathic school because of your engineering background, like just brilliant thinkers, right? So we need more people like that who are brilliant thinkers in medicine. And so he decided, you know what, this is very interesting. And he went to Russia and he found out. And then he came back to the German and approached the German government and said, listen, they have this amazing light therapy. It can be used for cancer, for depression, for anxiety, for immune system regulation, for arthritis, for all these things. And it's being used actively in Russia right now. So we need this. And the German government gave him money to develop the initial prototype. And he did. And he built a beautiful machine.
Well, Dr. Shah, this has been amazing. Thank you so much for everything you're doing, the person you are, for integrity medicine, and for driving this cutting edge technologies and communicating about them. So thank you so much for spending this time with me. I'm really honored and pleasure. Thank you so much.
The entity we have to thank is the one entity who's blessed us with certain things. And he continues to bless us, and he continues to give us things without measure. And so always have to thank God for everything.
God is great. Thank you.
100%, 100%. Thank you, my friend. Thank you so much for your time.
The information in this podcast is for educational purposes only and is not designed to diagnose or treat any disease. If you'd like to know more about what my center offers, please visit thekarlfeldtcenter.com. Please join us next week for another live consultation with a patient diagnosed with cancer on Integrative Cancer Solutions with Dr. Karlfeldt.